Good evening, everybody. I'm Kathy Antala, Vice President of Education at the Immunodeficiency Foundation, and would like to welcome you to tonight's IDF Forum, Managing Autoimmune Issues and Primary Immunodeficiency. This forum is being recorded. The recording will be available on the IDF website within the upcoming week. After the forum, everyone will receive an email, which will include a link to a short survey about tonight's program. The survey will also include an opportunity for you to tell us what you would like to hear about at future forums. Thank you in advance for taking a couple minutes to complete the survey when you receive it. Please remember that the information presented during this event is not medical advice, nor is it intended to be a substitute for medical advice, diagnosis, or treatment. Please always seek the advice of a physician or other qualified health provider with questions concerning a medical condition, and never disregard professional medical advice or delay seeking it based on information presented during this event. Well, for over 40 years, the Immunodeficiency Foundation has served as the trusted organization for the primary immunodeficiency community, with a mission of improving the diagnosis, treatment, and quality of life of people affected by primary immunodeficiency through fostering a community empowered by advocacy, education, and research. We totally value our role as a patient advocacy organization. And as a result of our mission, IDF seeks to ensure that everyone in the United States affected by PI has a fully informed understanding of the PI diagnosis that affects them, all available treatment options, the expected standard of care, and all of their opportunities for connection and support within the PI community. Whether you are an individual with PI, a family member, friend, or a healthcare provider, IDF is here to help. When you have questions about living with PI, health insurance, or more, simply go to the IDF website, click on Ask IDF, submit your question, and a staff member will be happy to follow up with you. If you're looking for support, IDF has virtual Get Connected groups throughout the year for all communities, for parents, individuals with PI, you name it, we are there. Right there in your home, get the support you need. If you haven't tried joining a Get Connected group, try it this week. Our groups are led by our wonderful Get Connected leaders who are volunteers. And if you are someone who says, you know what, a group maybe isn't for me, we have one-to-one peer support also. We have wonderful volunteers who are peer support, provide peer support one-to-one, and via phone or email, and they will be happy to contact you too. All you need to do is submit that request to Ask IDF. And as always, these forums are made possible by our wonderful sponsors. It is due to their partnerships and contributions that we're able to provide programs such as this one to everyone in the PI community. So at this time, please join me in thanking our 2022 sponsors, CSL Behring, Grifols, Takeda, Horizon Therapeutics, Accredo, Octapharma, ADMA Biologics, AstraZeneca, Pharming, X4 Pharmaceuticals, Kedrion Biopharma, Enzavant, and Chiesi Global Rare Diseases. Thank you. Thank you so much. And at this time, I would like to invite Roy from CSL Behring to share a few words with us. So Roy, you'll be able to unmute and show your video and take it away.
Terrific. Can you hear me?
Yes.
Awesome. Well, hello, everyone, and thank you to Kathy and the IDF team for the opportunity to be with you today. We certainly value the partnership that we have with the IDF and are grateful for opportunities just like this to engage and inform you of items and issues and all things impacting your community. So thank you very much for this opportunity. As mentioned, my name is Roy Pura, and I'm an Associate Director of State Government Affairs for CSL Behring. Of course, we're a global biotherapeutics firm focused on the treatment of rare and serious disease. Next slide, please. Could we advance to the next? There we go. So a critical component of many of our therapies is human plasma. And so we have one of the largest networks of plasma collection centers throughout the country, as this map illustrates. In the United States, CSL Behring operates over 300 plasma collection facilities, and our fleet continues to grow with the ever-increasing demand for plasma-derived therapies. Next slide, please. And there is certainly an increasing demand with the new indications for existing therapies, research and development to treat other conditions, and the continued supply of our current inventory. We're seeing the need for growth in our operations. With this, of course, comes the need for efficiencies in how we operate. This is where me and my team really come into play. In my role, me and my team work with state lawmakers and other elected officials, state agencies, and other stakeholders around policy and regulatory issues that may impact the efficiencies of our operations. For example, in the state of Connecticut this year, our team worked with a number of stakeholders, including IDF, to introduce legislation that would better enable the collection of source plasma in the state. This work required close collaboration with the Department of Public Health in the state to ensure that this agency could adequately operationalize requirements that are spelled out in the legislation. This bill did pass both chambers of the legislature earlier this summer, so great news there. In Ohio, our team is working with legislators and state agencies to introduce a bill to address antiquated staffing requirements for plasma collection centers in Ohio. Under this bill, additional qualified personnel approved by the Department of Health can staff particular roles within the centers. This is important as it would expand our ability to recruit and hire additional qualified candidates to fill critical roles in our Ohio operations. And then in California, our team is similarly working with state agencies and elected officials on legislation regarding workforce requirements in the state. Similar to Ohio, this legislation would expand the talent pool of qualified candidates to fill critical roles in our operations. These are just some of the current examples that our team is engaged in across the country, and we're certainly prepared to tackle other issues as they may arise as we continue to grow. Next slide, please. Of course, last but certainly not least is the work that my team does in collaboration with the patient advocacy community, including IDF, to educate key policymakers and educators and elected officials on the need to and the importance of plasma to treat rare and serious conditions. This is important work as healthcare continues to be relevant at the state and national level. The importance of educating key officials about the patients we serve certainly goes a long way when dealing with issues regarding plasma policy and regulations, and we're proud to stand with groups such as the IDF in this effort. So that's really all I wanted to share with you today, that there is policy that does impact the collection of plasma, and me and my team are proud to collaborate with groups such as the IDF on issues impacting this community. I hope this information, albeit brief, has been informative. Once again, thank you for the opportunity to be with you today.
Thank you, Roy. Thank you for your support and the support of everyone at CSL Behring and CSL Plasma. And now I would like to welcome Michelle from X4 Pharmaceuticals. Michelle, take it away.
Hi, Kathy. Thank you. Thank you so much. I want to give an extra special shout out to Kathy because I feel like Kathy is like the glue that holds me together sometimes and keeps me organized. So thank you so much, Kathy, for helping me get here tonight to join you and to just thank IDF. My name's Michelle Rhee. I'm a patient advocate at X4. Our mission is to develop treatments that have a clear and profound impact for people with rare diseases, including primary immunodeficiencies like WHIM syndrome and chronic neutropenia. And part of my job and part of the goal of the work that we do at X4 is to make sure that we're incorporating the patient perspective into the work that we're doing in pursuit of our mission, so that we're not just doing the work to help develop these therapies for patients, but doing it in a way that patients would want us to do it. So we're incorporating the patient perspective as a data point, sort of, in the decisions that we make. We sort of say that I think we might say it on the next slide, that there's this phrase, it's called like a FIPCO, which is a fully integrated pharma company, but we changed it to say it's a fully integrated patient-focused company, because in the pursuit to achieve our mission, what we're really hoping is that we want to put patients first as we do that. And we're really, really grateful for our partnership with the IDF and for everything that IDF has done for us and for the patient community, because for WHIM syndrome, the patient community doesn't have, like so many of these like ultra rare immunodeficiency communities, there isn't a disease specific patient advocacy group, and there aren't resources and infrastructure, like they can't have a webinar like this. And so we're really grateful for the opportunity to participate and to work with IDF. And we're also really excited. We were able to work with the IDF on a web page on the website about genetic testing. So you can actually go there and learn about this. This has a lot of writing on it. You can ignore the slide and just go to the IDF's website and kind of read up about genetic testing and about a couple of free programs. Pharming is also sponsoring a free program. So if you don't meet the criteria for ours, which is that you have neutropenia, they have other criteria. You might meet those, and then you're eligible for no cost. I think no cost genetic testing is what it's called. So thank you again, IDF, for everything that you do and for your partnership. And thank you for the amazing resources that you provide. So have a great night, everyone. Thank you.
Thank you, Michelle. Thank you for joining us, and thank you for everything you and your colleagues at X4 Pharmaceuticals do for all of us in the PI community. And at this time, I am honored to introduce our presenter, Dr. Terry Harville. Dr. Harville is board certified in pediatrics, pediatric rheumatology, allergy, and immunology, medical laboratory immunology, and histocompatibility and immunogenetics. Dr. Harville joins us from the Department of Pathology at the University of Arkansas for Medical Sciences College of Medicine, where he is the laboratory director of the ABG laboratory and a professor of internal medicine in the Division of Hematology and Oncology. So Dr. Harville, welcome. I will stop sharing my slides and you can just take it away.
Thank you, Kathy. Thanks for inviting me. And I'd like to thank IDF for allowing me to share my thoughts. Hopefully everybody can see my slide and hear me okay at this point. As Kathy has pointed out, that our goal tonight is to discuss issues associated with having autoimmunity and primary immune deficiency. I'm going to start with some disclaimers because these topics obviously are very complex and difficult. And the way I may be stating something may sound to be different from what others have told you, and make sure we get those clarified. Another issue is this is a topic that could spend hours and hours, if not days, trying to discuss and trying to make all the nuances and other issues clear. And in a short period of time, many things may be left out of what I present, but hopefully I haven't overlooked them regarding their meaningfulness. And so just to summarize what we're going to end up concluding with is that when we think about what is occurring with autoimmunity, it's the same processes that result in autoimmunity in someone without an immune deficiency are the same processes that result in autoimmunity in a person that has primary immune deficiency. And so autoimmunity is something that arises out of the immune system, but it's that are common to whether a person has immune deficiency or does not. And the treatment process has to be geared towards maximizing the benefit for the immune deficiency a person has, and then individualizing the care that is being provided for the autoimmunity so that the person is receiving the exact care they need to. Years ago, we had very few tools and treatment options. And so, for example, someone may be placed on prednisone or azathioprine or methotrexate because those are the medications we had that would treat autoimmune disorders. And sometimes they may work, but many times they didn't provide the full benefit we need. Now we have much more, and I'll be discussing a little bit of that later on in the talk. Another point to make out regarding autoimmunity is we now understand there are a group of conditions we call autoinflammatory. The features with rashes and fevers and other clinical components look similar to or identical to those that one may also be seeing with autoimmunity. The distinction between these is that autoinflammatory conditions are due to what we call parts of the innate immunity not functioning the way they should, whereas the part when we talk about autoimmunity are due to what we call the adaptive immunity, which is the components of T lymphocytes and B lymphocytes. And I'll explain more about that as we go along further. But as always, there are nuances, and things are always more complicated than what we want to be. And what we now know are that there are some 500 genes that have been identified where a person can have immune deficiency or autoimmunity or both in the same individual. And so this can make things a little bit confusing because a person may present first with an autoimmune disorder and then be seen by a gastroenterologist, a hematologist, a rheumatologist, who may not be recognizing or understanding that there's the possibility of immune deficiency being present. Or in the same family, one person may have immune deficiency, whereas another person may have autoimmunity without immune deficiency. So once again, making it complex regarding what is thought to be going on. And this slide won't be testing you on. This is just to give some idea of some of the genes that are known to cause problems for both with immune deficiency as well as autoimmunity. And if you look down the list of primary autoimmunity, you'll notice over and over that CVID, antibody deficiency are the primary immune deficiencies associated with the genes that we find responsible for causing primary immune deficiency. Additionally, the autoimmunities, you'll notice over and over there are hematologic gastrointestinal type problems that are the primary features that are seen over and over again with the underlying gene mutations. And so once again, in a family, someone may have CVID and then someone else may be presenting with hemolytic anemia and not appear to have immune abnormality. And so this makes things very confusing. If a person is being seen by a non-immunologist, then the evaluation of the immune system may be delayed. And so one of the important things is that people that are having any form of autoimmunity, that it must be considered that an underlying immunodeficiency could be present, or the genes responsible for immune deficiency could be present, and these should be evaluated for. And most places now can do the gene evaluations for most of the genes that have been identified for causing immune deficiency, and then use this to individualize the therapy. And that's going to be one of the things I'll be stressing through the talk. Another issue that's very interesting is what we call the HLA system, or MHC when we talk about this in regards to all the animals in the world. And if you note that right here in the middle on chromosome number 6, the short arm, that the item goes off the scale. Well, this is evaluation for associations across our chromosomes, which are listed here from 1 through 22, and then the X and Y chromosomes. And this is showing how frequently that area is associated with having an immune problem, specifically autoimmunity. And you can see that off the scale is HLA locus. Well, I don't have time to go into details about the HLA locus, but this is what controls the way our immune systems work. And so these are known as immune response genes. And so let's take this further and sort of try to go through thinking about this in a stepwise fashion. So who develops autoimmunity? It's the unfortunate individuals who have inherited some form of susceptibility, so the genes like we were presenting a moment ago, and then undergo some form of environmental factor that promotes the activation or causes the gene to function in a manner that promotes the autoimmune dysfunction that causes problems with an individual. And so when we think about this regarding patients that have primary immune deficiency, the same things would be occurring as if it's as in a person that is not thought to have any form of immune deficiency. And so now we know that there are numerous genes, as I've just been mentioning, that can cause immune deficiency, autoimmunity, or both. And in some cases, they may be responsible for just autoimmune manifestations without evidence of immune deficiency. And other cases that we may have both present in the same individual, but the point being that these genes can be resulting in autoimmunity, whether a person has immune deficiency or a person does not have immune deficiency present. And the exception to this concept is that autoimmunity may be more difficult to diagnose when someone has a primary immune deficiency. In particular, what's very frustrating to patients is that there are clinical symptoms present, the physicians are evaluating, there are abnormal tests, but nobody can give a name for the diagnosis. They just will say, well, you have some autoimmune process occurring. And it's very frustrating to not have a name that you can hang your hat on to then say, okay, this, now I know what I have, and now I know how to go to the next step of getting the appropriate therapy for that. And I just want to implore that physicians, that we're finding more and more things that the genes are responsible for that we don't have names for at this time. But by identifying which genes are present, we can go about specific individualization of the care so that people can do better. The other problem is that sometimes it can be more difficult to treat the autoimmune deficiency in a patient that is immune deficient because we're competing with the problems they're having with infections and with their immune deficiency. And if the therapy that's being provided is immunosuppressive, then it can make the infections worse. And so one has to create the correct balance between giving therapy that's going to be beneficial and therapy that's going to also make the immune deficiency worse. And now I'm going to go over the objectives of what I'd like for you to take away when we finish today. I hope you'll understand better aspects about what's going on in normal immune development, understand how normal immunity is trying to maintain what we call a homeostatic balance, and this to prevent disease manifestations in individuals. And then when this homeostatic balance goes awry is when inflammation and autoimmune symptoms can arise. Further, I hope that when we're done, that you'll understand that one of our best therapeutic interventions is the immunoglobulin replacement. And so providing even higher doses of IVIG can be beneficial to many people that have immune deficiency. And so the starting dose to treat the underlying immune deficiency may not be adequate to fully treat an autoimmunity. Also, one of the things that we're learning more about and understand better is that B lymphocytes have adverse roles in individuals that have antibody deficiencies, and that treatment with medications like rituximab for eliminating the B lymphocytes may be a very good approach to treat many of the conditions that occur. And as I keep mentioning, individualized therapy is what is required based on what genes are involved, so that we can treat with the best therapeutic intervention in order to make sure somebody does well. So one of the questions people ask is why is immunity present to begin with? And the textbook tells us that it's self versus non-self recognition. And that's not totally true, but I don't have time to really fully explain that part. It basically, though, the immune system recognizes self, and if it doesn't recognize self, it's when it starts this activation. What's interesting, the immune system evolved not to protect us from infections as it does today, but it evolved to allow for reproduction to occur, and as microorganisms became multicellular organisms. But again, I don't have time to discuss the completeness of that today, but I'm willing to answer the questions about that if anybody's interested. And then why autoimmunity? If we have all this process that's trying to provide us with protection and protect ourselves, why do we end up having autoimmunity? Well, the immune system became complex over evolutionary times, and we produced millions of different T lymphocytes and B lymphocytes. Now, each of these should have the capacity to be able to recognize something foreign in order that it provides immune protection for us. But during this development of this process of trying to make our T lymphocytes and B lymphocytes to develop the repertoire that's going to provide us with immune protection, we end up having some useful ones, but we also make useless ones, and ones that bind so tightly to self-tissue that it actually would cause autoimmune disease. Therefore, what we have to do is have a system to deal with this. And I call it the Goldilocks rule. And what we want to do is discard the useless and the too tight binding and keep the ones that are just right. And our body evolved with having this to work so that we can follow this process. And in doing so, more than 95% of the T lymphocytes and B lymphocytes that we actually develop are removed because they're either useless or could cause harm. And so this is a quality control issue. The immune system has to recognize the ones that are useful and the ones that are useless and the ones that are going to bind too strongly and eliminate them. And one of these processes we call central tolerization. And this occurs in the bone marrow for the T lymphocytes, or bone marrow for B lymphocytes, and the thymus for T lymphocytes. And what occurs there is a selection process whereby the immune system goes through and selects the T lymphocytes that bind just right and can potentially be useful, and eliminates the ones that can't bind, that are useless, and eliminates the ones that bind too tightly that would cause autoimmune disease. Therefore, keep the ones that are just right. Since this is a quality control issue, that sometimes we can't fulfill this process and eliminate all the useless and the bad ones. And so we have another process that we call peripheral tolerization. And this is a group of mechanisms that are found out in all parts of the body, in lymph nodes, the spleen, and the bloodstream, and in the liver, where the immune system undergoes other processes to try to prevent it from acting against self. One of these is called anergy, that occurs by overstimulation against self. Another is called apoptosis, energy was understimulation with self. And then there's apoptosis, where you have overstimulation with self that causes the cell to die. And then we have Tregs, which are doppelganger cells that are there that try to shut off an autoreactive cell. And so these things we all have to try to help control things, maintain homeostasis, prevent autoimmunity from occurring. But unfortunately, that even though these can work fairly well, sometimes infections, chemicals, and other factors may alter the ability of the immune system to control these autoreactive cells and allow them to promulgate and create problems. And then the issues I've already mentioned is if you have those specific genes present, some of the genes with loss of function and therefore decreased signaling can cause immune deficiency and autoimmunity, and other ones have an increase in signaling and are called gain of function. And so these can affect the way the cells are working and push cells towards autoimmunity or immunodeficiency, or both. And besides the tolerization process just mentioned, we have another buffering type process that occurs to try to help control things. And this occurs by counterregulation. So if one part of the immune system tends to rev up too much, another part revs up to turn it down. And so we have all these counter-regulatory forces that are at play, again, trying to prevent the immune system from going awry and acting out on self. And if, for example, if it starts skewing towards what we call the Th1, Th17 pathway, we end up with inflammatory disease like rheumatoid arthritis or psoriasis or ankylosing spondylitis. And I have a complex slide here that I want to step through just to give you an idea over the next few slides of how this counterregulation is occurring and what the parts of the immune system are trying to do. And so we start with a thymic immigrant. So the cell that has undergone the selection process is in the thymus, and this cell is naive. This cell goes under the influence of specific cytokines, IL-12, IL-18, to become a Th1 type cell. Now, Th1 is primarily there to look for and find virally infected cells and kill them off. And I know this is not a COVID talk, but these are the cells that are critical that are activated by the immunization to kill off the infected cells from the SARS-CoV-2. And that's why the vaccines work so well, is by activating these cells to help eliminate the virus. If the cell encounters IL-4, it becomes what we call a Th2 cell, and these are antiparasitic to protect us from parasites and promote B cell proliferation, B lymphocyte differentiation, and stimulate antibody production. And so inherently, these cells have an anti-inflammatory flavor, again, balancing out that inflammatory flavor that Th1 produce. And so they counter-regulate each other by the cytokines they produce. And so the gamma interferon produced by Th1 tries to slow down the Th2, and IL-4 and IL-10 produced by the Th2 try to slow down the Th1. We have another cell, it's called a Th17, that develops under the influence of what we call TGF-beta and IL-6. And this is there to try to help fight extracellular pathogens, so such as fungal infections. And so disease processes that have mutations that affect the IL-17 have a lot more fungal infections. And just parenthetically to help you understand, a mutation in what we call STAT3 results in a condition called hyper-IgE syndrome. And that mutation that lowers the function of IgE also lowers the ability of the Th17 to produce and develop correctly. And therefore, these individuals are more susceptible to having fungal infections. And that's why Candida is a major problem in patients that have hyper-IgE syndrome. Now, additionally, we produce those Tregs, those doppelganger cells, and these produce under the influence of what's called TGF-beta, and these are anti-inflammatory, trying to slow down the rest of the immune system to when it gets revved up. And finally, the Th17 produce specific cytokines, IL-23, for example, to keep the Tregs from turning things off until the infection is cleared. Because what you like to do is clear the infection and then calm things down. And so just to go over some principles over the things you're just mentioning to help you understand again about how the immune system develops and what the parts of the immune system are for, is our Th2 are there to provide us parasitic protection, antibody production. But if this gets driven to the extreme, we develop allergic disease. Further, if it's driven in an autoimmune fashion, we can produce autoantibodies, and this will produce, and this is where diseases such as lupus or SLE come from, and conditions, for example, dermatomyositis, Sjogren's syndrome, and these collectively are known as SARS group 1. So systemic autoimmune rheumatic disease subgroup 1. And so these are all have in common their Th2 type background. So once again, if you can identify the genes responsible, then you can help treat the underlying gene process rather than trying to give prednisone or something like this that have really bad side effects otherwise. Further on immunologic principles, those Th1 I was mentioning are there to help regulate the cellular immunity of our immune system, but also provide viral protection, mycobacteria, or what we call intracellular pathogens. And again, when this is overdriven, usually in conjunction with the Th17, we can develop autoimmune disease, rheumatologic disorders, such as rheumatoid arthritis. And these are also responsible for the graft rejection in organ transplants. And these are also responsible for the rashes and the inflammation that we see in disease like psoriasis. Th17, just to mention once again, protects us from fungal infections or other extracellular bacterial organisms. And it also has a role with autoimmune diseases like rheumatoid arthritis and psoriasis and graft rejection. Indeed, targeting the cytokines from Th17, IL-17 now as a therapy for severe psoriasis, and does a wonderful job of dealing with that. The T regulatory cells are there to help regulate things, and they're noted for their expression of what's known as FOXP3 inside of them. And they produce the cytokines called IL-10 and TGF-beta, which are responsible for downregulating the overactive other cells of the immune system. So, and these are responsible for what we call tolerance induction to try to prevent the immune system from overacting. And so these work in concert to counter-regulate each other, as pointed out, to try to create a balance or homeostasis, provide a balance to try to prevent excess inflammation, but also allow for protection against invading organisms. And so to illustrate this, here we have the interferon gamma that's produced by the Th1. They're turning off the Th2 if they become overactive. And likewise, we have the IL-4, IL-10 coming from the Th2 to downregulate the Th1 if the Th1 are becoming overactive. Further, if the Th1, Th17 have been overactive, the TGF-beta and IL-10 from the Tregs are there to turn off the inflammation being generated by the Th1, Th17. But as mentioned, that we would like for us to clear the infection before we shut off the inflammatory process. And therefore the Th17 produce IL-6, IL-21 that help slow down the Tregs until the infection is cleared and the level of IL-6, IL-17 drop off so the Tregs can become active. And so as this teeter totter shows that we're trying to create a balance between the inflammatory and anti-inflammatory cells with the Tregs trying to help maintain that balance, as well as the different ones pushing their level of cytokines to try to maintain that balance and prevent overinflammation, but also allow for fighting infections. And so quality control issue that we were mentioning a few moments ago is one of the major reasons that we may end up with autoimmunity. And this is because we end up with cells that can bind too tightly to self that aren't eliminated in those tolerization processes mentioned earlier. And the quality control failure is the reason why we could have autoimmune disease with people with otherwise normal immunity or thought that do not have any evidence of having immune deficiency. But it also is playing a role in patients that do have immune deficiencies. And the same genes may be involved in the immune disease process for both individuals. And many of these alter what we call signal transduction in the cells. And at the end, if somebody has a question about that, I have an additional slide I can show to help explain what we mean by that. So the bottom line is if you alter the signal transductions occurring in the cells, then you can have these potentially autoreactive cells be revved up so they react with self abnormally and result in autoimmune disease. The quality control setting, what's going on is we're producing more than 150 different antibodies and T lymphocytes. And if you have an immune deficiency that's impairing the development of these, so in the patient with the immune deficiency can't make the number 2 lymphocytes or the antibodies they need, then there are fewer things to select from. And so our immune system is trying to maintain a certain level of antibodies and T lymphocytes. And so it may start selecting ones that may be placing us at risk for having autoimmunity. And so our immune system doesn't want us to die from an infection. So it maintains some of the cells that might cause immunity, thinking that maybe that these will keep us from dying from an infection. And so to compensate for the underproduction of these normal antibodies to T lymphocytes, we may maintain these ones that are useless or too tight binding. And therefore, we have these around and can further promote autoimmune disease, or just the waste that's occurring from the useless ones can make people be unwell because your energy is being diverted off into cells that aren't helping you at all. And the ones that are retained that bind too tightly then may be responsible for autoimmune disease. And so we have this process where we end up with not eliminating these autoreactive cells to try to keep something to help fight infections, even at the risk of developing autoimmunity. Another thing that's relevant is we produce a whole new repertoire of our B lymphocytes for making antibodies every 2 weeks. And so while in the past, it's been thought that primarily the B lymphocytes were somewhat innocent, and it was the T lymphocytes control and change or lack of control over B lymphocytes was what resulted in autoimmune disease. It's clear now that B lymphocytes play a much more important role. And I'd like to see if I can illustrate that here if this is going to play. And it looks like it's not going to play. But what is being shown is that there are B lymphocytes and T lymphocytes interacting with each other. And their interaction is when the signalings are occurring, they're telling the signals from the T lymphocyte to tell the B lymphocyte to produce antibodies, but likewise the B lymphocyte acting up the T lymphocytes. And if these are aberrant ones that might produce autoimmunity, then this can result in the autoimmune state. Oh, now it's playing for me. And so you can see how these are marching around. And so B lymphocytes are can promote autoantibody production that can be occurring because of T lymphocyte interaction, but also they can promote T lymphocytes by antigen presentation to cause autoimmunity. And to give some illustrations of what I've been talking about, and so I'll call this issues. And one of the problems when we're dealing with these genes that can result in autoimmunity or immune deficiency is that patients may first be going to see an autoimmune specialist, a rheumatologist, pulmonologist, gastroenterologist, hematologist, et cetera, that because of the laboratory testing has been performed and the clinical symptoms that are occurring. And so just to help illustrate this, that many years ago, there was a little adolescent girl that was being treated for inflammatory bowel disease. She wasn't getting any better, and then started having increased infections. And her gastroenterologist and primary care physicians thought, well, it's a treatment, which is immunosuppressive, that's causing her problems. Well, finally, the family convinced the physicians to consult immunology. It was determined that she had antibody deficiency, she had CVID, and started with treatment with IVIG, and her IBD, or inflammatory bowel disease, started improving. And over time, she could stop all of the inflammatory bowel disease medications. Now, this was before we were doing the gene testing. And so I don't know which of those genes I presented earlier was the causative problem, but the bottom line of this is that that she had a condition where there appeared to be autoimmune disease, but the underlying problem was having primary immune deficiency, CVID. And to look at this type of further, we did a study where we looked for the whether patients with immune deficiency could be occurring and those that have multiple sclerosis receiving rituximab. And basically, from a very large database of patients, we found 404 patients with MS that were treated with rituximab. 53 or 13% of this group was subsequently diagnosed with primary immune deficiency. Now, we believe that they already had primary immune deficiency, but wasn't really diagnosed. And because MS was their main problem, they're being treated for that. And then the primary immune deficiency was unmasked once the treatment began. So once again, patients with primary immune deficiency and significant number of patients with MS may not have been seen by an immunologist first, but being seen by a neurologist or other physician that would treat MS. Treatment concepts, just to go over and some of the pertinent issues. IVIG is our friend for autoimmune disease, especially higher doses may be helpful. In some circumstances, IVIG may be better in sub-Q because you can get higher dosing in, or you get that bolus effect or spike effect with the infusion. For some autoimmune conditions, though, sub-Q may work just as well, and these things are being sorted out at the current time. Medications that are used to treat autoimmunity, whether a person has normal immunity or autoimmune disease, may be of benefit. And I caution against corticosteroids because these frequently are started and are difficult to stop, and they have multiple side effects, and there's a rebound effect. And so I usually suggest avoiding corticosteroids at all costs if we can, so that we don't end up with even more disease created by the medication. Other things to think about is rituximab, as being mentioned before, may be helpful by eliminating the B lymphocytes that are promoting the autoimmune disease. And so this may be useful as an early adjunct in the therapeutic intervention, along with continuing with the higher doses of IVIG. And once the symptoms are under control, there may be a way to discontinue the rituximab so that it can be controlled merely with the IVIG. The other thing along these lines to keep mentioning is that the genetic studies, if we can identify a gene responsible in a patient, then we can apply very specific therapy. For example, there's the PI3CA, the kinase delta mutation, which Kathy mentioned there's going to be discussion about that in a few weeks, that we know that using what we call an mTOR inhibitor specifically helps control the disease process in these individuals. And therefore, you can limit the therapy to just this type of medication, and therefore limit the adverse side effects that might be occurring with other ones. And we must individualize the particular patient's needs, looking at their genes and their clinical symptoms, and one size doesn't fit all. So you can't just use the cookie cutter dose and say that's going to be a benefit. And so to summarize what we've been discussing, the development of the normal immune system repertoire can also result in useless or potentially autoreactive lymphocytes and antibodies. And the Goldilocks rule, we try to control these by eliminating the useless and the autoreactive ones and keep the ones that are just right. But sometimes these don't work like they're supposed to because of the genes, the environmental factors, viral infections, chemicals, irradiation, other things that might allow the resurrection or promote the activity that these autoimmune reactive T lymphocytes. And I haven't had time to discuss it, but certain HLA types promote autoimmune disease in individuals. And if you've inherited the HLA type, you're going to be at even higher risk to develop an autoimmune disease, whether you have an immune problem or not. Patients with primary immune deficiency may be at higher risk for some of these problems because we're trying to preserve as much immunity as we can, and therefore retain cells that may have autoimmune potential. And so what we consider a quality control failure instead of eliminating these cells. And then we have the genes that may be promoting these factors and create the situation through very signal transduction abnormalities that result in the immunodeficiency as well as autoimmunity. These aspects of trying to control the balance by the cytokines, as I was mentioning in the cellular reactivities, may be more difficult to control if you have a deficiency in certain signaling or gain of function other signaling, so that you're skewing the pathways, for example, towards the Th1, Th17 and inflammatory immunity, or skewing towards Th2 and maybe lupus-like disease or Sjogren's syndrome-like disease. So B lymphocytes may be the immunity in many patients that have primary immune deficiency, especially CVID antibody deficiencies, because they're not making good antibodies and they're promoting autoantibodies and stimulation of autoreactive T lymphocytes. And so maximizing the immunoglobulin replacement, again, sometimes IVIG may be better in sub-Q, use of rituximab may be useful. Targeted therapy for specific gene mutations is critical now that we can identify the genes involved. And I haven't had time to talk about it, but there's an evolving role for JAK inhibitors where we can inhibit the correct pathways that are causing problems. And if we maintain the right level of medication, inhibit the pathway to maintain a balance in how the immune system is working and try to prevent the excess autoimmunity as well as having risk for having too many infections. So thank you so much for your attention, and I will answer any questions that I can.
Dr. Harville, thank you. Thank you so much for that wonderful information. We can hardly wait to ask you as many questions as possible. We're going to, for just a few minutes, have a word from our sponsors, Grifols, Takeda, Accredo, and ADMA Biologics.
Hi, my name is Ricky Mensch, and I'm one of Grifols' IG nurse educators. I'd like to talk about Grifols' resources for people on IG treatment with either Gaming XC 10% or Xembify 20% subcutaneous. Both products are for the treatment of PIDD and offer copay assistance of $10,000 per year for those that qualify. For those without insurance, please visit gamingxc.com or Xembify.com for more information about Grifols' patient assistance program. Both websites have infusion videos to answer common questions, informational brochures, and links to organizations for educational resources. Thank you to everyone listening tonight, and thank you to the IDF for having us.
My name is Dana Fladhammer. At Takeda, I am the Director of IG Community Support. You might know the team I'm lucky enough to be a part of as the MyIG Source Patient Advocates. I know that throughout my journey as a mom of 4 children living with primary immunodeficiency, the IDF has been simply an invaluable resource to me. I hope you learn a ton, and if you need us, know that nobody should ever have to do this alone.
Welcome to the IDF Forum. I am Kim Farrell, Product Line Manager with Accredo. Accredo is a best-in-class specialty pharmacy with a nationwide network of immune globulin-trained home infusion nurses and pharmacists. It is truly an honor and privilege to be part of this immune deficiency community. Accredo places patients at the center of all we do. We deliver individualized care and support for patients living with immune disorders. It's all about giving you a great and personalized pharmacy experience.
And at this time, we are going to begin the Q&A. I would like to introduce my colleague, Colleen Brock, Medical Manager at the Immunodeficiency Foundation. She is going to moderate this part of tonight's program. And you can continue submitting your questions into the Q&A section on your screen. And just to let you know, we received many questions in advance. So thank you, everybody who submitted those questions. We're going to answer as many of those as possible and as many as possible that were submitted tonight. So Colleen, carry on.
Thanks, Kathy, and I'm happy that everybody is here this evening, and I am excited about all the questions that we have received both before and during the presentation. And there were over 150, and if you've been around and heard my spiel, you're going to hear it again. There's no way we can answer them all, but that's why we're here with Ask IDF. And so if we do not get to your question, I encourage you to send it via the website, and you can ask your question through that, and we will be happy to answer it. We are also not going to answer any COVID questions tonight, as we have a COVID forum coming up, and that will be all we will be discussing that evening. So I encourage you to attend that. Then in the meantime, we have a lot of autoimmune questions and autoimmune related items to get to. So with that, let's get started. Dr. Harville, one of the questions that somebody had talked about was, could you describe the pediatric population and how they are affected, and I am assuming by peds 18 and under, how they are affected by autoimmune disorders? At what age do they start? How many do they usually have? Or is this something that the pediatric population kind of evades until they are older?
So that's a question that could spend actually hours on. And so I'm trying to keep it brief. So we have two aspects of things. One is having the underlying genes that are responsible for disease, and then having a promoting factor. For example, having an EBV infection. And so we see the same types of autoimmune conditions that we see in adults and children. We just don't see them quite as frequently. Part of that is part of the answer for that is, as I mentioned, that we make a new B lymphocyte repertoire every 2 weeks. So that means we have the capacity every 2 weeks to start generating new autoimmune antibodies. And so over time, you can see that if there's quality control failure occurring, you're going to start accumulating autoimmune antibodies. Therefore, in the non-immune population, for example, we start seeing an accumulation of individuals in their 50s, 60s, 70s with things like autoimmune hemolytic anemia, neutropenia, lymphopenia, various hematologic disorders due to the accumulation of autoimmune antibodies. Back to children, they haven't had the opportunity to do that yet. So most of the things we see in children are based on which HLA type they've inherited and then which things they've had exposure to. So for example, if a child has inherited HLA-B27 and they're female, that it's not uncommon to see a knee arthritis develop at about 3 years of age. And there can be other problems that can occur in those individuals. So I'm not sure if I've given you the specific numbers you wanted, because that would take a really long time.
Yes, and unfortunately, a lot of the questions that we have are not simple questions, or they're not questions that have a simple answer.
Right.
But I appreciate you giving it the time and the thoroughness that you can. So let's move on to, in talking about autoimmune diseases, I have several questions related to the why. Why do some people have more than others? Why do some have none at all? Do certain PIs make you more prone to certain autoimmune disorders? And if so, which kind? Things like that.
No, that's good. I can summarize my talk because that's exactly what I was trying to state for the presentation. So I'm sure that's probably a pre-presentation question.
Right.
And so again, to just point out, it's going to be the genes, it's going to be the underlying environmental factors, and it's going to be the HLA type of individuals has inherited. And so if somebody has inherited a gene that affects the way B lymphocytes work and antibody production occurs, then they're be more likely to develop an antibody deficiency or even CVID. And this, depending on the signal transduction pathway that's involved with it, it may also result in the production of an arthritis-like condition, inflammatory bowel disease, or lupus-like condition, for example, because due to the immune antibodies that are being produced. Now, some of these will be there more or less spontaneously because of the reduction in the function or the gain of function. But most of the time, something triggers this process to take off because the counter-regulatory processes were trying to control things. And so you have things in a very tight balance where not much is going on, and then somebody gets an infection. And I hate bringing it up again, but COVID. And then suddenly they generate 1,000 autoimmune antibodies that result in lots of autoimmune manifestations occurring. Influenza, Epstein-Barr virus, adenovirus, so Coxsackie virus, enteroviruses in general. These can all be the sort of the push it over the edge beyond what the immune system was able to counterbalance. So now the genes that were underactive or overactive or because of the immune system trying to fight off against the viral infection in the state of having underlying immune deficiency, you've skewed it off now in this autoimmune disorder.
Yes, it's very tricky and complicated. So when you're dealing with autoimmune diseases and you have an immune disorder, what is the best type of physician or physicians to take care of you?
It should be an immunologist. And the dilemma is that people that deal primarily with immunology are scattered apart. And so many areas of the country, we don't have as many people that primarily deal with immunology. And sometimes most of the physicians are allergy immunology. And the way we describe it is big A, little I. So somebody that primarily does allergy and some immunology, or little a, big I. So somebody that might do some allergy and some immunology. So the best way for this person to, and for anybody out there that's listening, go to IDF, put out your question, and then ask for which physicians may be nearby that can actually provide the benefit that you need.
Thank you. If I have CVID and I have no autoimmune conditions, am I still likely to develop them?
That's a really great question. And so part of it depends on why you have CVID. And so without knowing which gene may be responsible for causing your CVID, we can't predict whether you're going to have other problems or not. Now, what we can do is sort of look at the family history. So, and frequently I'll see in a family history, a person will have CVID and they'll have an aunt with lupus, or a sister with lupus, or have an uncle with scleroderma, or have a cousin with dermatomyositis. When you have this sort of family history type of thing, then you're concerned that this person will have one of the genes that's responsible for those SARS-like autoimmune disorders and may be at higher risk for developing one. But in general, if somebody is stable on IVIG, has no B cells, has good old-fashioned pure CVID with no B cells around, and had no very, very low antibody levels, missing almost no IgG A or M, then they're probably a little bit lower risk for developing autoimmune disease than somebody that has some IgG or some IgM or some IgA and some B lymphocytes still around.
Is it necessary to get the Pneumovax in order to determine if you have an immunodeficiency?
That's a great question, and I actually wrote the testing for this. This used as a white paper for the Quad AI, and my answer is yes. It's a simple answer. Now, the reason for that is that for the control of our immunity to be able to produce antibodies that are meaningful, protect us from most of the microorganisms, we have to produce these antibodies that can bind to these specific polysaccharides. And so while the pneumococcal vaccine would give us only 23 tests that we can perform, that if you fail to mount a good response, that is good evidence for having a primary immune deficiency. If you mount a good response, that's a good evidence that you don't have a primary immune deficiency. And so we use that as the dividing line. The corollary in here and the nuance is that insurance doesn't like paying for a very expensive product like IVIG or sub-Q-IG. And so you have to prove that there is need for the products. Further, we don't want to be treating somebody that doesn't really need the product.
Right.
And so therefore, the long answer for the simple answer of yes is that you need to check the pneumococcal to justify the therapeutic intervention and to prove that the underlying immune deficiency is present, so that you can justify the therapeutic intervention and the insurance and everyone involved is in agreement.
Somebody asked this evening, does the waste of useless cells cause the fatigue experienced by people with PI?
You know, I wish I knew that answer directly. And I put that in because it's clearly going to be a nutritional waste. You know, if you have, it's like this is a poor example, but if you have something growing in you or on you, like a parasite that's taking away your nutrition, then you're not going to feel well. And so that's the way I sort of look at those types of cells. But the inflammatory cytokines, such as TNF and gamma interferon, make somebody feel fatigued, have a fever, feel very achy, have photophobia, so that the light bothers their eyes, makes the sound bother their ears, and makes them feel chilled. And so they want to find a dark place to hide and cover. And so when the immune system, not to belabor it, but it's not the virus that's making you sick. It's your immune system reacting to the virus that's making you sick. And so these cytokines that are being released occurred over an evolutionary pattern to allow us to survive. And so instead of it just activating the immune system, if we're sick and we could, millions of years ago, little creatures running around, and we couldn't evade a predator, then we're not going to pass on our genes. So if you have, you're sick and the TNF is making you light bother your eyes, you feel cold, you feel achy, you want to sleep, you go find a hollow tree or a dark cave, and you lay there and sleep it off until you're healed from the infection. And then you can go back out and not be caught and eat by the predator. So unfortunately, our immune system is causing these feelings, this fatigue that occurs. And again, don't want to mention COVID, but I'm doing research in the area, and shamefully, I'm going to say I'm presenting on long COVID at the IGNS meeting in a few weeks, and be talking about the cytokines and so forth that we've seen that are responsible for some of those features, and looking at these other individuals and seeing that these cytokines appear to be responsible for those features, because when we block them or do things to alter them, the fatigue, the mental fog improves.
Interesting. Okay, so I've had a couple of people ask this evening, could you please explain the difference between CVID and hypogammaglobulinemia?
Okay, so blah, blah, blah. Organize my thoughts, I'm sorry.
You're fine.
Yeah, so let's say hypo, so HYPO gammaglobulinemia means the immunoglobulins are lower than the expected normal range. So for example, depending on the laboratory, the lower end of normal for IgG may be 800 milligrams per deciliter, and someone may be sitting at 600 milligrams per deciliter. And therefore, they are by definition hypogammaglobulinemic. In the old days, before we had other testing to do, for CVID, we defined it by having IgG levels below 400 milligrams per deciliter and absence or low IgA or IgM, typically low IgA. So you had to have a low IgA and an IgG that was lower than 400 milligrams per deciliter, and also have a B lymphocyte count less than 200 cells per microliter. So there had to be deficiency in B lymphocytes, IgG, and either IgA or IgM, but typically IgG. And that, again, before we had these other tests to look at things. And so that was utilized to make the definition for CVID. And therefore, people made a distinction if you were not less than 400 milligrams per deciliter. And so that was called hypogam. So all these conditions where the immunoglobulin is less than the lower limits of normal is hypogammaglobulinemia. And then CVID usually includes the other features of having low B lymphocytes. Now, this has changed over the last few years. And so we look for other things in addition. We look at the subpopulations of B lymphocytes and see where they are. And so now we can define CVID not only by looking at someone that has a lower IgG level, a low IgA or IgM level, and then having B lymphocytes that are disproportionate for the populations that should be present type thing. And so now somebody with 600 milligrams per deciliter can be diagnosed with CVID if the B lymphocytes are off and they fail to mount a pneumococcal response. And so this is in some ways loosened up the definition, but it's also helped allow for the definition to be more meaningful by adding in the other factors in there. Further, this is being utilized in that kind of fashion for helping to justify the need for immunoglobulin replacement so that you can justify that treatment for the individual. And so again, in the old days, when the definition was 400 milligrams per deciliter, someone could have 750 milligrams per deciliter, make very poor responses to pneumococcal polysaccharide antigens, but the insurance say, well, it can't be CVID because it's not less than 400 milligrams per deciliter. And so again, many of us have been working on changing these things so that the therapy can be included. So hypogam just means just below the lower limits of normal. Many physicians will start using these things interchangeably, or if they feel they can't provide a precise diagnosis of CVID because something is missing or something isn't in place to say, oh, this is simply CVID, then they'll divert to using hypogam. Dysgammaglobulinemia is another term that's utilized. Selective antibody deficiency is another term that's utilized to indicate that there is a problem with antibody deficiency, but not wanting to call it a specific name, CVID, XLA, X-linked gammaglobulinemia, et cetera. So hopefully that helps clarify that.
Thank you. It's a good segue into the next stuff that we're going to talk about, which is lab work. So what is the best way for people to be tested for autoimmune disorders if they have an immune disorder where they're getting Ig replacement?
Yeah, so that's a great question because I can't tell you how many patients that have dealt with where either they, because they're on IVIG or sub-Q Ig, they now have hepatitis B antibodies due to immunization. They have a positive ANA. They have something that rheumatoid factors occur, antiphospholipid antibodies occur, all these things occurring. And again, I'm shamefully mentioning that COVID produces over 1,000 different autoantibodies in people, and that I suspect that we're going to start seeing a lot more problems with autoantibodies in our plasma products as these donors are putting more of that into it, which is going to make even things more confusing and all. So the bottom line there is testing for antibodies like an ANA and so forth is unreliable on somebody who's receiving immunoglobulin replacement therapy. What sometimes we've done in the past, if somebody's getting IVIG, is, and they get an infusion monthly, is immediately before their next infusion, look for autoimmune antibodies and see if anything is detected, because that may have some benefit at that time, especially if they're at higher levels, because what would be coming in from IVIG or sub-Q Ig would be lower level values. So for example, someone suspected has thyroid autoimmunity, checking it at right before the next infusion, and I find that the thyroid peroxidase antibody is very high, I trust that that's probably a legitimate response. If I found the thyroid peroxidase antibody was just barely abnormal, then I would worry that it was more likely from from receiving the product. So that part said, the things that we do are we look for the HLA type. if somebody inherits HLA between 7, we know they're at risk for spondyloarthropathies, including inflammatory bowel disease, psoriatic type diseases. Someone inherits DR4, they're more at risk for post-streptococcal diseases, rheumatic fever, rheumatoid arthritis. Someone inherits A1, B8, DR3, they're more susceptible to the SARD, so the lupus-like conditions. Someone inherits HLA, DQA1, 501, DQB1, 201, they're at 1 out of 7 risk for developing celiac disease. So these things are very helpful for pinpointing. So HLA testing we use extensively to help pinpoint us towards individuals that are going to be at risk. Then the next level will be doing the underlying genetic testing. And so I didn't have time to go over this in the talk, but let me spend a couple of minutes going over that. There's several levels. They're what we call targeted panels. And I'm not going to name any specifically, but there's a targeted immune panel with nearly 400, I'm sorry, almost 500 now, specific immune genes present. One of the manufacturers mentioned them and that if they have certain symptoms, that they can get the assay done for free. So there are ways to try to get that done, but it's only targeting those known genes where there's a high association between autoimmunity and immune deficiency. The next level we do is what's called whole exome sequencing. And what that does is that sequences all of the proteins in your body that would be expressed, and then they're sent through computer algorithms to look for changes in the DNA that are associated with specific disease processes. Unfortunately, it's not uncommon for some of these to be listed as what's called a value of a VUO, or a value of unknown significance, which means that it's not known for sure whether it causes a problem. But there are computer programs that can analyze the mutations and analyze how that changes the protein structure, and then will give a pronouncement of whether it's suspected to be pathogenic or not. Then the next level is what we call whole genome sequencing, where you not only sequence the parts of the proteins that would be expressed, but you sequence all the parts of the genome that even that's not expressed, because many of those parts control the expression of specific genes. These things used to be fairly expensive in the past, but now the cost has come way down, and it can be justified for somebody with autoimmunity, especially with autoimmune immune deficiency, to try to sort out what's going on. The capture rate for being able to use these types of things and definitively find is only about 25% though. But what you do is every few months you reanalyze the data, because as more data are accumulated regarding having underlying immune abnormalities, your sequence that was done today, the differences, the polymorphisms may not be identified as causing a problem. 3 months from now, they can be identified because now it's known that that specific thing causes a problem. So this is an evolving process that's going to continue to evolve as more data can be gathered in there.
Interesting. Can you share your thoughts on positive GAD65 in a child less than 1 year old?
Okay, so that if the child was not on the immunoglobulin replacement, I'm worried about a couple of different things. One, that is going to be risk for diabetes, and then the other, there's risk for stiff man syndrome. And the other things that we've seen in patients with these is that when you look at the way the brain signals, that different proteins, different amino acids, different neurotransmitters are involved in how neurons signal and transmit with each other, how some neurons may be turned off and how other neurons may be turned on. The GAD antibody can affect what's known as the glutamate pathways of signaling the brain. And so you can get an imbalance of the glutamate pathways and the GABA pathways, and you can end up having quite a bit of problems that can occur in these individuals. They can be from not having much motion to even be towards catatonia, can have racing thoughts, unusual thoughts, can become paranoid, and can have a lot of things going on. So this is an antibody that I worry very much about, and would have to look at what's occurring with the child. There are other tests that should be done. One of them is called a Cunningham panel to look for specific autoimmune antibodies of the brain. Another one's called Genocopia, which looks for specific autoimmune antibodies of the brain. And we look at these all together to see what's going on to be able to try to direct therapies towards those items. In these types of patients, we look at their cytokine panels to try to see which ones are out of whack, in addition to, again, help guide what's going on. And again, I hate self-promoting, but we have a study going on looking for patients with autism, trying to look at these different autoimmune antibodies and see how they segregate in different subpopulations or subgroups of individuals with autism, and looking at their immune activity regarding their cytokine, chemokine panels, so we can start doing specific therapeutic intervention. In adults, we are doing a similar study where we're looking at their HLA type, their cytokines, chemokines, and the autoimmune antibodies of the brain, so we can start trying to define which groups might receive very specific therapy. For example, high-dose IVIG. Right now, our therapeutic intervention, we're planning on using, because of our success in a small number of patients that we've dealt with, we're planning to use JAK inhibitors and titrate the JAK inhibitor to help deal with the problem. So I would worry a lot about an infant that had a GAD65 antibody. They need to be further evaluated.
Thank you. And I know that the person who submitted that question thanks you. We're going to talk a little bit about medications. So CVID, ankylosing spondylitis, they're on IG replacement and Celebrex. Is that an okay combination because they have severe side effects? Is it the combination medications, or is it they need to try a different IG replacement?
You know, that's great. Now, are the side effects infusion side effects with IVIG, or is it something else, or do you know?
I'm not sure.
Yeah. So I've not patients that give Immunodeficiency 2 and Celebrex, I've not had that combination create any adverse side effects. Celebrex is relatively gentle and straightforward and can be fairly helpful. If somebody is between 7 positive with ankylosing spondylitis, then they likely need additional therapy beyond what's being given with the therapeutic intervention.
I missed that they're also on Cimzia, CIMZIA.
Okay.
Sorry.
Yeah. So that's yeah. And so that's probably the what's being used.
The culprit.
Yeah. And I'm blocking which one that I can't remember all the names of the different ones. But that's that it's I think it's one of the JAK inhibitors similar to Rinvoq. I can't remember off the top of my head. I apologize for that.
No, that's okay.
So the bottom line is that they're getting that part. And so it sounds, if the problem is that they're having only infusion related issues, that there are several things that can be done. One, there are medications that can be used to try to limit or try to mediate or prevent some of the side effects due to the infusion. There can be giving a bolus of normal saline, a liter of normal saline before an infusion can prevent a lot of people from having side effects of the infusion. I use a medication called Diamox to try to prevent some of the side effects. And so things like that can be done. Changing to a different immunoglobulin replacement product, so one brand to another brand. Some people tolerate a different brand better, or switching to sub-Q. Switching to sub-Q frequently takes away the side effects. So if this is an infusion-related side effect, then focus on that, but make sure that they need to make sure that they're adequately taking care of their ankylosing spondylitis, so they're not receiving or won't be developing some of the other adverse side effects that occur from that, or the morbidity associated problems that can occur.
Okay. You had mentioned that you should try a higher dose of IVIG to help with the autoimmune problem that you're having. How do you determine what is a higher dose? Is it a certain percentage above baseline?
Well, just it can vary from person to person for their needs, but in general, to somebody gets IVIG, and let's say they're getting IVIG half a milligram or 500 milligrams or half a gram per kilogram every month. Okay, that's a typical dose that many patients are on. Some physicians start with 400 milligrams per kilo, but most that are doing immunology start minimum at 500 and go up from there, because the studies that were done that show that higher dosing does better. Okay, so somebody has active autoimmune disease and that they note that they receive some benefit when they receive their infusion of 500 milligrams per kilo, but after a week or two, the benefit is gone. And so they get a week's benefit and they have 3 weeks of no benefit. So the options are, for example, taking 500 milligrams per kilogram twice a month. So every 2 weeks, receive that dose and see if they can keep 2 weeks of benefit in there. And if not, then increase the dose. So you have two options: the frequency and the actual volume that you're giving. The higher the volume, I mean the gram dosage that you're giving. So the higher that you go up, so once you go past 1 gram per kilogram per dose, so you're giving 1.5 to 2 grams per kilogram, that you rapidly lose the excess immunoglobulin over 3 to 5 days. So you're back down to a level of about 1,000 milligram per deciliter in your body. So that spike may be a benefit, but you don't get prolonged benefit from it in certain circumstances. So giving a dose of half a gram per kilo every 2 weeks, 750 milligrams per kilo every 2 weeks, a gram per kilo every 2 weeks, a gram per kilo once a month, whatever works for that patient is what you try to shoot for. And some patients I have, it's a gram per kilogram every 3 weeks, and that works great for them. And that's what we stay with. And then this can be translated back to sub-Q for somebody that, for example, that it's difficult for them to receive IV every 2 weeks, for example, or they have poor veins. Well, you increase the sub-Q dosage equivalently, and you can get benefit in some individuals by doing that. It's just sometimes it's a little bit harder because the volume you're trying to put in is a little bit more.
Thank you. I have probably 20 questions about rituximab.
Yeah.
They range from, is it useful in ITP in 22q11 to it has been associated with poor COVID outcomes and is not helpful with a patient with CVID, to can it cause a return of non-Hodgkin's lymphoma if they have had it previously and now are on it. It is a variety. It's also another question as to how do you manage biologics and immunosuppressive medications. But there's a lot of concern about Rituxan. Rheumatologists that say they can't order it for their patient with RA because they have CVID. Where do we stand with Rituxan, and what do we know about how it works and if it's okay to use?
Yeah, that's great. I'm going to start it actually at the end and work through some of those things and just chat about rituximab and maybe cover the bases people are looking for. Okay, the last thing is that, and this is something discussed with many immunologists over the years. And a couple of the ones that are very, very, very prominent, known, and I've discussed, that we think that if you have CVID and you're 40 years of age, we should just start rituximab. Continue your IVIG at a good dose and just start rituximab.
I've heard that.
Okay. And that's to try to prevent many of those things that were being discussed there, type of thing. So the rheumatologist not prescribing just doesn't understand that when you're on IVIG, you don't have any problems anymore getting rituximab. The problem is giving rituximab without IVIG or sub-Q IG. That's when you run into problems. And that's like I was noting with our study, we were looking at MS, that these were patients that got rituximab that were not given IVIG and subsequently diagnosed with having primary antibody deficiency that should have been looked for up front and treated up front with immunoglobulin replacement that would have prevented some of the morbidity associated with their therapy for their MS. So the bottom line is that rituximab affects what we call circulating B lymphocytes that express a marker on their proteins, a marker protein on the cell surface called CD20. It does not affect antibody production. It does not knock out what are known as plasma cells. So if you have something where you can, like you've been immunized against tetanus in the past, and you have plasma cells to make tetanus antibody, you do nothing to that by giving rituximab, because plasma cells are still present that can make the antibody. And so rituximab, the reason it helps in all these conditions is because you remove this antigen-presenting cell that's activating the T lymphocytes. And so the main function of rituximab is to stop that T cell activation process. Then that allows those other T cell components that we're mentioning to counterbalance the process and calm everything down, to calm down the autoimmune disease that's occurring, type of a thing. So things that were being mentioned, that ITP frequently responds with rituximab, and IVIGs, usually higher dose IVIG. In some of the cases, I've had to use, in addition, a TNF inhibitor, and that's a separate issue. And somebody was mentioning about the juggling the biologics and so forth.
So if you are on Rituxan or rituximab and they want to change it to a biosimilar, which is better, the actual rituximab or doing a biosimilar, or does it matter?
It doesn't matter as far as I can tell from the data. Okay. So let me, there we go. And so this might help. I'm just going to show this to help people think about what's going on, visualizing it. And so we talk about all these signals that are occurring and acting on a cell, that the way this works is sort of like vector addition. And so how that cell responds is going to depend on how the signals add up. And so therefore, if we can block a signal in one way or the other by like one of the biologics, we're going to affect the way that cell's outcome is going to be. And then, activation occurs in this case. Now, they're talking about biologics. Okay, here we are. These are many of the things that we have biologics directed against. For example, the anti-CD25 is commonly been used. The anti-CTLA4, abatacept, is commonly used. The anti-CD11A, I'm blocking on the name of that, but that was being used for multiple sclerosis until people started getting a lot of adverse side effects from it. The IL-17 is being used to treat psoriasis now, and it's being used to treat also ankylosing spondylitis and rheumatoid arthritis. Anti-IL-1 receptor antagonists are used to treat rheumatoid arthritis, a variety of inflammatory diseases, anti-TNFs, anti-IL-12s. And so anti-IL-13 is now one of the new ones that's used to treat asthma and allergic disease, and was found to be beneficial in keeping people that had severe COVID on the ventilator. If you gave them the anti-IL-13, they survived better than people that did not. And somebody mentioned worsening COVID. I know we're not supposed to be talking about COVID with rituximab, and the studies indicated that with severe disease, rituximab was beneficial. And for example, individuals with XLA without any B lymphocytes survived COVID much better than people that had B lymphocytes present. And so little boys with XLA with no B lymphocytes present and can't make any antibodies at all did much better with COVID than equivalent individuals that had normal immunity and normal B lymphocyte counts. And so it can be considered to be a juggling process, but in my mind, it is you target what the individual needs based on, for example, their cytokine panels, on their gene they're involved, and then give them an anti-IL-6 or give them an anti-IL-17 or anti-TNF or IL-13 or anti-IL-4 or anti-IL-6. Or you can use a JAK inhibitor that affects many of these. And let me see if I can get to that a second. And so here we have the JAK inhibitors, and I know it's hard to read the small print, but you can see how the different ones that are being named and how they affect different ones and how they affect the different diseases they're associated. Sarcoidosis, inflammatory bowel disease, psoriasis, alopecia, Behçet's disease, lupus, rheumatoid arthritis, etc. And so I think that as we go further, when we're talking about the biologics, we're going to be talking about a lot more using these JAK inhibitors in a correct fashion to try to help be able to down-regulate the pathways to creating more of a problem to reestablish a balance. So we don't want to shut everything off, but we want to reestablish that balance where we don't have excessive inflammation, but we have enough immune function to prevent us from getting infections. And
so we're talking some heavy duty things. So who are the doctors that are going to understand all of this? Is it going to be the rheumatologist? Is it going to be the immunologist? I mean, when you're talking about trying these things for autoimmune disorders that are very debilitating for people, lupus and MS and all of it, who are the ones that understand all of these and not just sort of the regular ones that everybody goes to?
That's a great question. What my thoughts are in our model that we're working with is the immunologist, okay? But I'm working with neurologists to help guide them. They're seeing the patients. I consult and I guide them on the therapeutic intervention.
Okay.
And so I think that this, again, your question is that that more of the immunologists have to become versant in these things.
Well, I know people are looking at all of this, and I know that somebody who is somewhere outside of a major city hospital is going, my doctor isn't going to understand any of this. They're not going to have a clue how to put me on any of this.
That's correct.
That is where the consulting immunology program comes in with at IDF. You can have your physician contact us through the consulting immunology program on the website, and we can have doctors talk to them. But, you know, as a patient myself, as knowing others that struggle with finding somebody who understands all that you have presented this evening, where do I go keeps coming up. How do I tell my doctor this? How do I get my doctor to understand this? Somebody just posted, you know, I told my rheumatologist that some of my testing is not going to be accurate because I'm on IG therapy. And they told me they were offended and it wasn't true. Well, that person is right. Some of the tests are going to be wrong.
That's correct. And because of the IVIG immune modulating properties, some of the things that the person may have been looking for may have been downregulated and couldn't be found even though disease is present. So no, I I talked to other physicians about this, and one of my colleagues, we have a special neurology clinic that we hold every Wednesday for patients that have complex situations and very unusual processes. And the problem we turn into is I examine the patient and find they have a huge thyroid, and many of their symptoms are related to thyroid disease.
Mhm.
And they'd been placed on thyroid medication by an endocrinologist, but they told me I was the first physician that had ever examined their thyroid. How can that be? How can a person be placed on thyroid medication by an endocrinologist and not have their thyroid felt and evaluated and examined? It's a failure. If anything, I hate saying in the soapbox, but it's a failure of our medication system by putting things under insurance and putting things into a profit process rather than having a really truly nonprofit scenario where stockholders are those that are dictating who gets therapeutic intervention type of a thing. And dictate that the physician, you've got 2 minutes you can spend with this patient to find out everything that's going on with them. It just doesn't work.
And
And
that's
so-
one of the things IDF is fighting for. We are
Yeah.
fighting for all of you and getting people to hear us that it's not simple. It's not easy. You cannot put a round object into a square hole. You have to listen to what we're telling you. All the things that you tell us, we hear. But I'm gonna ask you just a couple more questions on one topic, and then we're gonna go, because like I said, we could be here all night. There are so many important questions.
I want to implore the patients, if there are questions that really didn't get answered the way you wanted to, send them in to the IDF, like they've noted, and we'll get an answer to you one way or the other on there, okay? And and have your physician email me or contact me. Go to the IDF and you might find somebody local that can help you. If not, find somebody that go to the IDF and have them contact me, or have your physician be willing to get in contact with me, because I'm willing to talk to them and guide them through the things that they can do on there.
Yeah, and we're here to help. We just need to know what you need help with.
Yeah, my
But
role.
let's talk about Sjogren's.
Yeah,
Because
Sjogren's.
and we'll end with Sjogren's, because I have a lot of questions, not a lot, but I have several questions about Sjogren's.
Right.
Why is Sjogren's a common comorbidity, and what is the best way to diagnose it? And also, is it common for somebody with IgA deficiency to have Sjogren's?
What if I had time, I'd pull up my medical student lecture where I talk about Sjogren's syndrome and just go through the lecture, but I know we don't have time for that. So let me just talk about it instead. Okay, so Sjogren's syndrome can be primary or secondary. And so when it's secondary, it's in association with lupus or it's in association with rheumatoid arthritis. And so when it's an association with lupus, it's in that SARS pathway where you're taking that Th2 pathway and you're influencing the development of the Sjogren's syndromes as well as your lupus-like syndromes. The antibodies that are found in Sjogren's syndrome, SSA, SSB, are very commonly found in patients with lupus, even without clinical features of Sjogren's syndrome. And so the features being the swollen parotid glands being the main feature, dry eyes, dry mouth, dry eyes, being the common features we'll see of that, having periodontal disease because of the dry mouth and so forth from that. And then you can have more extensive problems elsewhere in the body too, from achiness to occasional other things. But primary Sjogren's is not going to affect the other things too much. And so if you have, if you're having systemic disease with your Sjogren's, then you're very likely having the lupus-like features that are overlapping with it, or the RA features overlapping with it. So RA is a Th1, Th17 disease. So it's opposite of the lupus type diseases. As I was showing you, the Th1, Th2 try to counterregulate each other. And so what you have going on here is that when you develop a condition like RA, you crank up the Th2 type pathways to try to calm down the Th117 pathways that are causing the RA to occur, the rheumatoid arthritis. In doing so, you can promote lupus-like features and Sjogren's syndrome type features. And so it's very common then for people with RA to have Sjogren's syndrome there because it's part of the immunity that's trying to calm down the RA, and it actually is promoting Sjogren's to occur in those individuals, type of a thing. So Sjogren's can occur from both of those types of scenarios in there. I'm going to let me think what I need to. So Sjogren's and IgA deficiency. IgA deficiency is there are you can think of it in sort of two forms. One is common IgA deficiency with no other disease, and that occurs in about 1 out of 300 to 600 people. And we know that because Blood Bank in Tennessee examined all the blood that was being donated 1 year, many years ago, to look for IgA, and about 1 out of 400 something people had no IgA present, yet they were all older adults that had to say, I don't have any illness, so I can donate blood. The other IgA deficiency is really part of CVID. It just hasn't got to CVID yet. And so this may be 1 out of 3,000 individuals, and you lose your IgA first. Then you start losing your ability to produce certain antibodies. During that time frame, the IgM may go up a little bit, compensating, and then you start seeing a fall off of IgG. IgG comes in 4 subclasses, and frequently subclass 2 and 4 start falling away. So first 4 disappears, and then 2 is going down at the same time, and then may disappear. Then the 1 and 3 go down lower, and you have a total IgA deficient, total IgG deficiency, and you have IgA deficiency. And if you looked at it at that point, you said, oh, this is CVID, where it started with it being IgA deficiency, but over a dozen years really became what we diagnosed as CVID. So IgA deficiency itself has no direct bearing or mean on Sjogren's syndrome, but having IgA deficiency that's part of the spectrum of CVID means you're going to be at risk for having autoimmune diseases like Sjogren's syndrome. So Colleen, you had some other specific things that I probably didn't address. Ask those so I can make sure this is clear.
No, those are very good. And it's interesting because the other one I had is this common for a patient with Sjogren's as well as immunodeficiency in IgG and IgM. And they suddenly developed polyclonal hypergammaglobulinemia.
Yeah. When your immune system is failing.
So that's what you're talking about.
Yeah. That what happens sometimes is that you start overproducing IgM because IgM doesn't require any T cell help in its production. And the quantity of immunoglobulin that's supposed to be present, the detector is saying, I don't have as what I'm supposed to be seeing. And so because it's too low, and the only thing it can turn on is IgM. And so the IgM goes up. And so I've had so many patients that were being referred or there's concern that they were developing lymphoma or developing MGUS or multiple myeloma. And when I say, no, this is what you see with CVID, evolution of CVID, and then eventually the IgM may reach very high, 2,000 milligrams per deciliter, and then starts tapering off and then drops down. And then you've got an IgG of 200 milligrams per deciliter, IgM of 50 milligrams per deciliter, and IgA that you can't measure. And that's not uncommon for an evolution process. So if you look at it at a static point, you get confused because you see your IgA is low, the IgG may not be that low, and the IgM seems to be elevated. And so you're confused because you don't see the evolution of it or the dynamic of the process.
Well, I can't thank you enough. I mean, you have answered so many questions. And like I said, we could go on and on and on. And, you know, I suggest to all of you, if you have not had your question answered and you want an answer, please submit it through Ask IDF. That's what we're here for. And things like tonight, are amazing and we learn a lot. And Dr. Harville, you have been fantastic. And I appreciate every minute that you have donated your brain cells, your time, your presentation, everything that you have done to help us all learn, because I think every single person here tonight has learned at least one thing. I know I have.
I've always wanted my patients to learn and know as much about their disease as I could.
And it's not an easy thing to learn.
It's not, but I've had patients that I would allow them to quiz the medical students to put people in their place. And that would take, so to try to help somebody understand that they need to listen to their patient so that they can understand. The old saying is that if you listen to the patient long enough, they'll tell you exactly what's wrong with them.
Yeah.
That's what we try to do. And then I want my patients to understand what's going on, because then it makes the job of treatment much easier, and takes away some of their fear of what we're trying to do with the treatment. When they read the label that says all these things can happen when you take this treatment, it makes you very scared and afraid. And if you understand what you're trying to do, then it makes it go much better.
Well, that comes across in your talk and it's greatly appreciated.
Thank you, Cohen.
Kathy, it's all yours.
Oh my goodness. Dr. Harville, you know what? I could listen to you all night long, and I know that you would stay here with us all night long. You are just amazing. You're amazing in the way of brilliance and in the way of advocating for those of us in the PI community. I honestly cannot thank you enough for the time you have spent with us tonight, and hope now that you can enjoy the rest of the evening. Thank you for making us so much smarter, and you are wonderful.
Oh.
Thank you, Kathy.
And along with next, I would like to thank our featured sponsors tonight: CSL Behring, Grifols, Takeda, Accredo, X4 Pharmaceuticals, and ADMA Biologics. And also, I would like to thank each and every one of you who joined us tonight, who submitted questions before this forum, during the forum, and whether you left before the bitter end or you hung in there with us. We love you dearly. Have a great rest of the week and take care. Good night.